You're tuned into the AdvoSci Health Podcast, where we explore the forces shaping health and humanity. A space for bold questions, powerful stories, and honest conversations, with voices striving for a better tomorrow.
Welcome back, everyone. You're tuned into the AdvoSci Health Podcast, where we explore the forces shaping health and humanity. Over the past few decades, we've seen major strides in global health, more children surviving, more mothers receiving life-saving care, but inequality, malnutrition, and preventable deaths still define the start of life for millions. And there remains growing crises, from climate change to conflict.
To help us explore that, we're joined by one of the world's leading voices in the field. Dr. Zulfiqar Bhutta is a globally renowned researcher and advocate, founding director of the Institute of Global Health and Development at the Aga Khan University, and co-director of the Center for Global Child Health at the Hospital for Sick Children in Toronto. His work has shaped global policy in collaboration with WHO, UNICEF, and continues to guide efforts towards equity and better health for women and children worldwide.
Yep. Dr. Bhutta, it's an honor to have you with us. Thank you so much for joining us on the ASH podcast. Feel free to introduce yourself as well.
Well, you've already introduced me. So I'm Zulfiqar Bhutta. I do many things. I've been working in global health, and one of the things that I do is to work with young people. So I've been very blessed over the last 30, 40 years to be working with almost a generation of young scholars, students, trainees, research staff who have worked with me on many issues of global and national relevance across the world and still continue to work and guide me. So I'm very pleased to be with you.
Thank you so much once again. It's a pleasure to hear from you and your experiences. Maybe we can start off with an initial question to get the ball rolling. So, seeing as you started as a pediatrician in clinical work and you continued in such a way for a long time, while you had done research work during that time, what motivated you to kind of switch entirely towards global child health research?
So it wasn't a sudden switch. It was a more gradual process. But my reason to step out of the safety and security of a tertiary hospital, the four walls of the Aga Khan University, to do much more primary care, community, rural work was very simply as an effort to try and bridge the great divide that seems to be emerging between urban and rural populations, between the haves and have-nots, between those who have resources and can go to large tertiary referral hospitals and others who don't have access to even basic primary care. So that disparity, that inequity in global health was something that I became aware of very early on in my career when I went back to Pakistan in the mid-80s and tried to set up a clinical program. And my movement from a clinical perspective, a pure clinician running a large intensive care unit for newborn infants at the Aga Khan University, to a program of peri-urban, urban, and rural newborn care was a learning process. It was an effort to try and understand some of the social determinants of health, some of the drivers that impeded progress, but importantly to find solutions to what could be done with limited resources, with what we had and what we could bring to the table to help communities and also learn from communities. So that move was more gradual than your question implied, and it was very deliberate. It was something that I did myself for my own learning, education, and also to provide me with that sense that I was making a meaningful difference.
So then, having made this move, and like you said, it was a gradual process, you have now been in the field of health, global health research or child health research for many, many years now. From your perspective, what progress do you think has been made in child and maternal health globally in the past, let's say, 2 decades?
Well, first and foremost, the world hasn't stood still. At the time when I began my work in global health, exploring some of the things we were thinking of, how best to align global priorities around an aspirational goal for the world's leaders, countries around women and children's health. That led to the development of the Millennium Development Goals, which were first negotiated in big Millennium Conference Summit in New York towards the end of the year 1999, 2000. In September 2000, I think it was signed into a global compact. It's called the MDGs, and a big part of the MDGs was women and children's health, and a very aspirational target to reduce unnecessary preventable child deaths by 2/3 by the year 2015, and maternal deaths by 3/4 by the year 2015. At the time when these Millennium Goals were coined, it wasn't really clear how this would be achieved. There wasn't as much money as people wanted. There wasn't as much clarity on what interventions would make a difference. And there wasn't that global compact around implementation. It's just that countries got together and said, this is what we need to do for low and middle income countries, for poverty alleviation, for improving health. Well, slowly, steadily, momentum picked up. And by the time we got to 2015, the world had almost reached the Millennium Development Goal 4 targets for child mortality, and did reach it for many other indicators like elimination or tackling extreme poverty and reducing maternal deaths. So today we are in a much better place than we were back in the year 2000. And progress has been enormous. In certain countries, it's not been the same all over the world. The larger countries, the relatively well-off countries like China, Brazil, India, have been able to reduce child mortality, maternal mortality quite significantly. Others have lagged behind, but everybody's made some progress. So today, as we speak, we don't have 10 million children dying under the age of 5 years every year in the world, as was the case in the year 2000. Today, we have less than half of that number. And that's only been possible because of the collective good of governments, policymakers, politicians getting together, agreeing on a common mission, and a lot of technical folks, a lot of advocates, academics, researchers, and healthcare professionals getting together to ensure that things were implemented.
Thank you so much for that answer. I think for sure it had to have been an effort over a whole world problem. It couldn't have been done in one fell swoop. So thank you for describing it that way.
Yeah, and just to add to that as well, I really like that concept of the collective good, and I feel like that progression on a mental perspective it tends to be gradual, and it tends to require like a lot of conversation and coordination. So obviously, like when you mentioned those statistics, I was amazed at the fact that we're less than half of that number now, and definitely it's like a huge stride. And I feel like that is a mindset that still continues to be built between countries and for the collective good. So in your opinion, what do you think are the most persistent gaps as of now in the current decade that maybe still keep us from achieving health equity for women and children?
Well, I mean, as I said, I think although we have reduced mortality quite significantly, the same cannot be said for every child health related adverse outcome. There's lots and lots of children who are living in conflict zones, in pretty disadvantaged situations, abject poverty. And I'm not just talking about low and middle income countries. I'm talking about countries like the ones in North America, where you have resources, but they're not distributed in a way that those who don't have the ability or access or are marginalized on the basis of race or ethnicity, they don't have the same rights and resources as others. And so this disparity or inequity, which is an unfair inequality, is amongst us. it is much more stark when you look at it from a global perspective across the world, because the countries that are now currently facing some of the biggest challenges around child survival, child health, development, long-term consequences are countries in polycrisis, in the middle of conflict, climate change, disasters, population migration. All of these things are intertwined. And they are the countries which have close to around 40% of the total burden of newborn and child mortality. So a lot can and should be done, and it can be done pretty reasonably if we got our thinking hats together and were able to somehow or the other implement this at scale.
Thank you so much for that answer. I mean, the way you've talked about countries that are still struggling, but have made some strides, we have seen that South Asian countries have made strides in maternal and child health, which you mentioned as well. Cases such as Bangladesh's BRAC model, Afghanistan and Pakistan's polio programs. Do you feel that there are lessons from these South Asian countries or these countries that have made strides that other global health actors could adopt or should consider adopting?
I think it's already being adopted. Bangladesh had one of the first model of community health workers, which were launched by an NGO to reach various parts of the population which could not be reached by physicians and more highly trained professionals. Remarkable success, was able to bridge the gap, reduce the disparities between urban and rural populations. Then they've also launched some of the same approach in urban slums, again to better effect. So these countries that have made progress, the so-called exemplars who have made progress despite not the same level of economic growth as rich countries, all of them have followed examples of quality interventions implemented at scale with the right level of the health system. They've all given advantages to their population through investments in social determinants of health. Things like education, family planning, better living conditions, water, sanitation, hygiene, safety nets for extremely poor in terms of even things like food support, which helps prevent maternal and fetal malnutrition. So there are these examples of investments in countries which have been remarkable and have been remarkably consistent across our global experience. So in many countries, that tacit knowledge of how to address things directly and indirectly has been very important in that global progress. And the few where the residual burden of mortality now lingers are places where we need to reach out and do the same, but at scale, and based on the best experience that we have around what works and what doesn't work.
Yeah, thank you so much for sharing that. And I think it's very important what you said about like how our question was actually like, what can they adopt? But they're already adopting it. And it's more so about a scaling issue, which is something that didn't come to mind for me. And I think, like progression is like that. It doesn't necessarily have to start from scratch. It's more so figure out what's working right now, and then how can we scale it further for those that need it. So that was a very important point that you raised. And maybe just switching gears towards talking about evidence-based policy. I know you've worked a lot in that. So what do you think is the biggest obstacle to turning research that one has outputted into meaningful policy?
The first thing is, there is research and there is research. There are trials which are very small, and there are other large studies which are at population level, generally cluster randomized trials, or sometimes not even trials, sometimes just longitudinal cohorts or observational studies. All are important. All are important. But at this stage, we have enough knowledge from what has been implemented within health systems, what seems to have worked, what hasn't worked, to be able to put together a palette of evidence-informed, highly effective interventions that every country should be thinking of implementing in its own population. They range from things like care during pregnancy to the care of the baby in later pregnancy, the whole period of childbirth, which is so risky for many of our mothers, um, and then soon after birth, transitioning to early neonatal period. All of those are important, and they need that level of interconnectivity for primary care health systems to deliver.
Of course, I think you're 100% right. Where if you don't have a connection with policy and health, then it just doesn't work. And I love how you said that there's research and then there's research. Of course, not all research will be going into some large scale policy reform, but I think we would all agree that all research is important in its own right. I think the next question I want to ask, sort of similar timeline, is, and it kind of stems from recently I saw an article that talked about global health funding and how it's becoming a crisis. A lot of it stemmed from the US withdrawing, I think it was roughly $9 billion, which consisted of, I think, 67% of, 21% of the Global Health Fund. And we've seen that obviously these bigger countries, they have a lot of donations, they have a lot of money that is helping the world, but that creates almost an unwanted or unconscious dynamic. I'm not going to say power dynamic, but that leads me to ask, do you think many global health conversations are dominated by high income institutions or countries? Or if you would think that a more delocalized ecosystem is better, what would that look like in your opinion?
So, localization and devolution are good things because they bring services and accountability very close to where people are. So I'm a great believer in the fact that you should not have everything clustered centrally, and therefore rural provinces, remote districts don't get anything in that trickle down process. But having said that, it's important that this be done right. That when you do devolution, that you create mechanisms for governance, oversight, support, accountability that allow you to monitor what is happening. And you shouldn't have to wait 3-4 years for things to go south to realize that some of the implementation issues were challenging and not necessarily in the best interest of the population. So I think what we are beginning to recognize is that the devil is in the detail around how do you reach people, how do you make public sector workers and government facilities functional. And then for things which are principally the forte of the private sector, given the resource requirement for some of those, like newborn care, like intensive care, those things can be, all done in a manner that does bring in some philanthropic funding, but also relies on the government's own resources in setting it up with a network of referral system. In the context of women and children, the vast proportion of newborn deaths can be averted in primary and secondary settings, district level health systems, where you have at a community level either outreach workers who go out and help women and their unborn or soon to be born a child, or they can focus their attention in addition on referral systems and making good quality care available in facilities. Be that as it may, devolution or passing of resources to districts or smaller units only really works if there is accountability, if you are using some measure to monitor what is changing and what is not changing. And that is a weakness in many government systems, in that their information service is around routine births and deaths very poor, and therefore they rely upon these periodic surveys to give you a sense of what is happening, increasingly in remote and rural areas.
Of course, I can see how with that, as someone who's donating or a country that is providing funds, they might maybe be more reluctant because they cannot get the proper information or data available. And we've seen how if there's a sudden withdrawal, as USAID withdrew from many countries earlier in the year, many countries were left, I don't think the right word, but maybe panicked or stranded. I know that when you look at funds for donation for global health, it's usually seen as a humanitarian point of view, but there has been talk about less donations and more in the form of loans. Do you think where like the countries you talked about that may already have maybe a political issue or are suffering from global debt, that is a potential solution of shifting more towards loans for healthcare rather than donations?
Well, I don't believe in donations.
Okay.
I think until you have skin in the game, you may only put 5% or 10% of a project cost on the ground. But until you put that in, it's not your baby, someone else's baby. Okay? So I am a great believer in mobilization and availability of local resources at country level for local problems and local causes. I also think that the governments can do a much better job of governing and oversight. And then importantly, moving to a system of accountability which is based on real life district health information systems. So there is absolutely no reason why this district health information system cannot be primed to address challenges around implementation in the districts for maternal newborn child health or nutrition, and hence reduce the undue and inappropriate reliance, if you may, on periodic surveys, which are very expensive and which have now been stopped.
Yes, of course. Thank you so much for that insight. I think I do agree with the idea of donations doesn't really work if you have a skin in the game, because you should be trying to help yourself as well as a country.
Yeah.
There is a saying in Urdu says, "Male muft dile berehm." So, anything that you haven't really appreciated or got is not necessarily appreciated in the same way as something that you bought yourself. And that's a fundamental principle of life.
That's actually a very good point. Yeah, I think we should be using that more.
I'm very more often.
Yeah.
Yeah, and maybe just to speak on that aspect of like localizing your district resources, like maybe talking about Pakistan as well. What kind of resources could they be using right now or doing things differently in order to kind of revamp the way they approach this?
In Pakistan, are you specifically talking about post-devolution?
Yeah.
Well, devolution was a good thing. And it gave more power to the provinces. And some of the provinces ran with it and never looked back, because the minute they all of a sudden got the resources, and resources also came accountability. In other instances, they were not really ready to take on that charge, and there was a negative impact on programs. But, that kind of an impact on a health system is not unheard of. And it happened in Pakistan after devolution in, some years ago. Now there is talk of a new amendment to undo devolution of certain subjects from the provinces back to the federation, things like education, family planning. There are reasons for it, because those programs have not done very well in the provinces. They have floundered. The Lady Health Workers program that I am very proud of having worked with from very get-go, it really suffered post-devolution, because nobody really wanted to own it. So in Pakistan, there is now a real opportunity to rethink exactly how social sectors funding can be restored, can be given priority, which is education, family planning, environmental health, and maternal child health. And all of those subjects are important. Now, in other countries, you sometimes have a federalized but a devolved system for health. Canada has one of those. Here health is a provincial subject, right? There are some policy matters which the federation, which Ottawa would jump in, but rest are all up to the Ontario government to invest and to make sure that it invests wisely. But who's going to tell a local government whether or not they're investing wisely? That comes in the subject of monitoring, evaluation, and empowerment of communities to stand up and ask for their rights.
Of course. I think, yes, for sure. I love the comment of who's going to tell countries to how they share their finances. I think that becomes another topic that I kind of want to dive into, which is of leadership. Well, we've seen the issues around the world when it comes to global health or child and maternal health. And I think, as you being someone who has been in this field for a long time, if you could see the future of child and maternal health, what kind of leadership do you think should be in place to address the evolving challenges?
Well, this is what worries me, because I do think there is lack of global leadership right now, particularly around women and children's health. And some of this lack of leadership is related to also us having taken our eyes off the sustainable development goals. I mean, there was the COVID pandemic, then followed that by wars, Ukraine, Middle East. The world has been distracted. And as a result, therefore, progress that was continuing in the MDG period up to 2015 has slowed down. So what would I like to see in an ideal world? I'd like to see greater governance, greater political ownership of the rights of women and children. I would like to see more work on trying to see what could be done in humanitarian and conflicts settings, and particularly for women and children on the move, migrants, refugees. I'd like to see a lot more evidence-informed interventions in that space. So whether it is in war settings or non-war settings, I've written extensively about it. Rehabilitation, getting services in to address some of the mental health issues of children, post-traumatic stress, ensuring that they have support not just in health, education, nutrition. All of those things are important. And we need to do that as a global community, just like we did in the Millennium Development Goal period. But sadly, also at this time, the world is also facing a nationalistic backlash, with countries becoming much more introverted and much more insulated from the rest of the world. I think that's a mistake. And it will come back to bite us down the road, whether in a couple of decades, when we suddenly realize that at the end of the day, it's only one planet. If one part of the planet is unhealthy, the rest of the planet cannot be healthy. How many walls, how many barriers will you put up? I mean, in this global crisis of climate and environment, many of those challenges are transnational. And they are challenges for all the world. And we see that on a regular basis in our issues related to social determinants and drivers of health. So having a healthy Africa, having a wealthy Africa, having a healthy and wealthy South Asia, and avoidance of some of the challenges like conflict, these are critical things which will influence global health and development. So no country is insulated. Look at what our Prime Minister in Canada is doing, is really trying to create connectivities, business and work opportunities in Asia, elsewhere. So you can't really envision our world in isolation these days. We are an interconnected humanity. We may look different, we may, wear different clothes, we may have different skin colors, but at the end of the day, as Homo sapiens, we are on this planet and we are on this together, and we face its challenges and also partake of its fruits and benefits altogether.
Absolutely. I think that's a really huge point that needs to be stressed across, because as we're seeing throughout even just the past decade, we can see what you said about like insulation and fragmenting the world has done, especially on a global scale, when you do have things like, for example, the pandemic itself. There's so many social determinants of health that were just exposed all of a sudden, and then we come to question why and how. But it's really that fragmentation that has built across and continues to be normalized that pushes us away from actually building that interconnectedness that you talked about. So that's a huge thing, and I hope that, like you said, that mindset kind of shifts in the near future. Otherwise, it's hard to build solutions. And maybe just moving to, as I know we're getting close towards the end of the thing, the
Yes.
podcast itself, but maybe just talking a bit about your career as well. What do you think? What are you most proud of when you look back at your career, and maybe what unfinished business still drives you currently?
Well, it's the common faith in our common humanity, actually.
Hmm.
It's the realization that, you know, Allah created us as human beings, placed us on this planet for a purpose, and that purpose is to lead a life of purpose, which means that we, as human beings, should do everything in our power to alleviate suffering, ill health, and deprivation all over the world.
Hmm.
And the most vulnerable, the most susceptible, and the most ill-equipped of all human beings on the planet are its children. I mean, children are the measure by which societies are judged in terms of how they protect, nurture, and raise the next generation.
Yeah.
And children are also the future of the world. So therefore, whatever we can do to make this world a better place for its children, for its youth, for its adolescents, is a worthwhile investment. What drives me personally, not just these days, but has driven me from my student life, is that faith that at the end of the day, all of us as human beings want to see this world as a better place for our children and for the people who will inherit it from us. And after almost half a century, I haven't given up on that ambition and on that aspiration. So, you know, I just turned 70 this year. And at this age, I look back, as I said, to my own youth, and my own school days, college days, university days. And some of the things that drove me at that time are still things that drive me today. So, and they keep me going. And they also give me hope that despite all the ups and downs, that we will, inshallah, emerge one day as a better world for our children and for people who don't have enough resources.
Of course, I cannot agree more. I think if we cannot fix this world for the future generations, then what can we do? I think that's why they say maybe like a parent's instinct is the strongest thing, because you want to do everything for your kids. And I think that's a great driver for global change. And I hope that's something people adopt more. I will try to as well. So see what we can do for the future of humanity, for ourselves. But as we now come towards the end of our absolutely wonderful conversation, thank you so much. Just a reminder that these solutions in global health don't always flow from top to bottom, but often emerge from communities themselves and from the people and from their ambitions like yours.
Absolutely. And I've learned more, as I started off our conversation by saying, from people, young people like yourselves. I learn more from children than perhaps children learn more from me over the years. Thank you.
All right. Thank you so much, Dr. Bhutta, for being here and having this wonderful conversation. And to our listeners, thanks for tuning in as well. Don't forget to subscribe to the ASH podcast for more conversations on things like this and the intersection of science, policy, and humanity. We'll see you next time.
Thank you. Khuda Hafiz.